And we'll now go ahead with our next presentation, and it is my pleasure to bring to the podium to present to you Dr. Kingslow.
Hello, LA. Thank you for having me here at the NMA. This is, I think, the third time we've done the pulmonary hypertension lecture. I'd like to thank our sponsors, Actelion, United Therapeutics, and Gilead for helping support the program and providing lunch and all the logistics in this regard. As we said, we're going to talk about current and future approaches to the treatment of pulmonary hypertension. And let me get my bearings here. My disclosure statement. This graphic represents the pulmonary artery. As you can appreciate, this is a diseased vessel. It looks like an artery of a cancer. The intima is thickened. Here we go. Oops, sorry. The intima is thickened. There's a onion skinning of the muscular layer. The adventitia is thickened. There's debris and scarring within the lumen of the vessel. This vessel is thick. It's abnormal. It's tight. It doesn't relax. The pressure in the vessel is high. The pulmonary vascular resistance in the vessel is high. It ultimately results in the right ventricle failing, and if untreated, it ultimately results in this patient succumbing. There's been significant gains in the management of this disease over the past 20 years. We now have 14 medications available for the treatment of this disease. Without treatment, the median mortality is 2.8 years. With treatment, the median mortality is about 8 years. So this is like a malignancy. We need to approach these patients as if they have a terminal disease and address their disease process early and aggressively. Otherwise, they're going to succumb. This is a graphic of Natalie Cole, who recently died from having pulmonary arterial hypertension. And this is a reminder that not only is, although it's a novel disease, we're seeing more and more of it in the general population. And it's also a reminder that there are healthcare disparities, and pulmonary arterial hypertension patients are not immune to those disparities. And when we look at the literature, we see that patients in marginalized and underserved communities are underdiagnosed and also undertreated. And it's unfortunate because there are segments of the pulmonary arterial hypertension population, subsets, who have an increased propensity for this disease. Folks with scleroderma, folks with lupus, folks who have HIV, folks who have portal pulmonary hypertension from cirrhosis and hepatitis C, and also folks who have sarcoidosis. So those of us who are on the front lines of serving marginalized communities need to keep this in mind, particularly when we're faced with those patients who have unexplained dyspnea. So again, the median survival with no treatment is 2.8 years, and if we follow these patients out at 5 years, 70% of these patients are going to be dead. And if we look at those patients who are at high risk for early demise, there are those patients who have an elevated mean pulmonary artery pressure of greater than 85 millimeters of mercury. These folks are dead within 12 months. If their mean right atrial pressure is greater than 20 millimeters of mercury, they're dead in 1 month. If their mean cardiac index is less than 2 liters per minute per meter square, they're dead in 17 months. This is a mortal disease. So we don't have time to waste, to pontificate, to think, to worry, and not treat. We have to identify these patients quickly, and we have to get them on the road to treatment immediately. This graphic represents the number of medications that have been developed since 1995 to treat this disease process. And there's some things I want you to take from this. One, there's an ongoing progression in trying to identify new and better medications to optimize management of this disease process. We have recent medications, 4 recent medications within the last 3 years: oral treprostinil, macitentan, Riociguat, and selexipag. Most recently in December of 2015 that got approved. In addition, I want you to recognize that when listing the categories of medications available for use, calcium channel blockers are not listed here. They are non-FDA approved medications for the treatment of this disease. If your patient has pulmonary arterial hypertension and they're on a calcium channel blocker, unless it's approved by a specialist in this arena, it puts the patient at a higher risk for death and demise. So these medications should not be used in patients with PAH unless approved by a pulmonary specialist in this arena. And lastly, I want you to recognize that the prostanoids, Epoprostenol and treprostinil, are the gold standard in the management of this disease process. And the reason why I say that is because when we look at data historically, we're finding that patients are not optimally treated with this medication, and in turn, they're succumbing at an earlier rate. This is data from the REVEAL study. REVEAL is a multi-centered registry that has registered about 5,000 patients worldwide to monitor for short-term and long-term outcome data for patients with pulmonary arterial hypertension. And this graphic looks at all-cause death, medications that patients were on at the time of their demise. There's almost 1,000 patients. And what they found was that at the time of death, about 43 patients were not being treated with the gold standard medication. And even 8% of the patients were not on any medications with this disease process. So it tells us that patients with pulmonary arterial hypertension, even after diagnosis, are undertreated. There's data looking from Sitbom and his colleagues that asked the patients once they are diagnosed, how many doctors have you seen before your diagnosis of pulmonary arterial hypertension was landed? And on average, it was 3 physicians. And it took them 18 months to 24 months before the diagnosis was landed. So they're being underdiagnosed, they're being diagnosed too late, and they're being undertreated. And we have to remedy this as clinicians. So this slide just points to the fact that we're focusing on pulmonary arterial hypertension and not pulmonary hypertension. These medications that we're going to talk about are indicated for patients with pulmonary arterial hypertension. There may be some patients with pulmonary hypertension, like those COPDers or the sleep apnea patient or the patient with interstitial lung disease, that, in which there's a subset of patients that may qualify and meet criteria for medications for pulmonary arterial hypertension, but that requires the teasing out of the experts. So the rule is that the medications we're discussing are for pulmonary arterial hypertension. There's chronic adjuvant therapy that we use in the management of this disease. This slide is in your handout. I'm not going to go through this in detail. We did present data here a few years ago regarding exercise and pulmonary arterial hypertension, and I just wanted to pay a little bit of attention that it's indicated in all patients with PAH. We recognize that it improves 6-minute walk distance and endurance, improves quality of life, and we think that there may be some mortality improvement as well. So I just wanted to put some highlight on that. As far as general measures, pregnancy and pulmonary hypertension don't mix. Pregnant patients who have this disease die, 50% mortality rate in that population. So we want to avoid those patients from getting pregnant if they're of gestational age. We use 2 forms of birth control to control for that. If patients are of gestational age with pulmonary arterial hypertension, there's 2 classes of medications that we want to avoid in these patients, the endothelin receptor antagonists and the soluble guanylate cyclase medications. These are teratogenic, and hence we avoid these medications, and we monitor if they're of gestational age, and we place them on these medications. We monitor for pregnancy by doing serial pregnancy testing. Immunization speaks for itself. Psychosocial counseling is warranted. This is an overwhelming disease. You're telling a young lady who's 40 years old that she has a potentially terminal disease, they're going to get depressed. So we refer these patients to psychiatrists and psychologists. We ask them to get involved with support groups. As far as air travel, all of us, when we flew into LA, we were in a cabin pressure that was pressurized to 8,000 feet. Our partial pressure of oxygen dropped by about 30%. Those of us who are hypoxic at sea level, when we travel, we become more hypoxic in the air. So in patients with advanced pulmonary arterial hypertension, I typically advise my patients not to fly. We can do testing in the office and do log regression analysis equations to try to predict how much oxygen they're going to need in flight. But if you're hypoxic at sea level, you probably shouldn't be getting in a plane. The same thing goes for diving and high altitudes, kind of speaks for itself. And then surgery, we really want to avoid dropping our patients' preload with pulmonary arterial hypertension. It increases their risk for not being able to fill their left ventricle. You can't fill your left ventricle, your blood pressure is going to plummet, and you're not going to get recovered. We've unfortunately had patients who've undergone conscious sedation in the setting of advanced pulmonary hypertension who've succumbed in the dentist chair, or who've succumbed in the doctor's office getting a simple lipoma removed. So we have to be aware of that. We want to avoid general anesthesia if at all possible in patients with advanced PAH. And if they have to go under the knife, they should have a Swan-Ganz catheter in place and close monitoring in the operating room. You want to have an anesthesiologist who's well aware of this disease process. So current treatment options for pulmonary arterial hypertension, again, calcium channel blockers are non-FDA approved therapy for PAH. It requires patients to meet strict criteria. Only a small smidgen of patients with this disease process meet criteria for calcium channel blockers. The PAH-specific therapies are endothelin receptor antagonists, PDE5 inhibitors, prostanoid therapy, soluble guanylate cyclase therapy, and selected prostacyclin receptor agonists. And we're going to talk about them in detail as we go forward. These are the approved therapeutic targets for management of pulmonary arterial hypertension. And we'll walk through this. There's three pathways: the endothelin pathway, the nitric oxide pathway, where there's an underproduction of nitric oxide, and the prostacyclin pathway, underproduction of prostacyclin. With endothelin, endothelin 1 is a potent vasoconstrictor. So we want to block its ability to attach to its receptors. We use endothelin receptor antagonists to block this scenario. That's bosentan, ambrisentan, and now macitentan. The nitric oxide pathway, there is underproduction of nitric oxide. We can use exogenous inhaled nitric oxide in the operating room to potentiate more cyclic GMP and vasodilate. We can block the production of phosphodiesterase type 5, by giving phosphodiesterase type 5 inhibitors, allowing more production of cyclic GMP. And one of the newer agents that's been available since 2013 are the soluble guanylate cyclase agents. Soluble guanylate cyclase is an active signal within the nitric oxide pathway. When we stimulate that chemical, it binds with nitric oxide to potentiate more cyclic GMP, hence vasodilating the vessel. And then the prostacyclin pathway, we have two types of prostacyclin analogs, Epoprostenol and Tresprostenol. They've been on the market 20 years and 14 years respectively. They're both potent vasodilators. And we also have the non-prostanoid IP receptor agonist. This upregulates the IP receptor so that our own circulating prostacyclin binds to that, allowing for potent vasodilatation. So we're going to focus on the prostacyclin derivatives, epoprostenol and tresprostenol. Epoprostenol is an IV medication that requires a continuous infusion. Tresprostenol is delivered both IV, oral, inhaled, and subcutaneously. It offers a more nuanced and varied approach to allowing us to use this agent in the management of this disease. Prostacyclins are the gold standard in the management of pulmonary hypertension. This is the pivotal study published now 20 years ago in the New England Journal of Medicine. It looked at epoprostenol versus conventional therapy being oxygen, diuretics, digoxin, and Coumadin. And what they found within 12 weeks was that patients on the conventional therapy were dropping dead, whereas those patients on IV epoprostenol were surviving, 100% survival. So this rapidly became the gold standard in managing this disease, and this was the only medication that we had available for us for about 6 or 7 years. The problem with this medication is that it's intravenous, it's cumbersome. It requires 2 good sets of hands and a well-working brain to utilize. And a lot of folks, because of its intensity of use, as well as the lack of familiarity of making this diagnosis, a lot of folks were still dropping dead from this disease process. I'm going to switch gears and switch us back to the nitric oxide pathway, and we're going to focus on the soluble guanylate cyclase stimulator, which again binds to nitric oxide, potentiates cyclic GMP and vasodilatation. The pivotal study that allowed for approval of this medication was the patent study that was published 3 years ago in the New England Journal of Medicine. It looked at Riociguat, which is a soluble guanylate cyclase stimulator, and it compared it to placebo in almost 400 patients. They had primary and secondary endpoints: 6-minute walk distance, pulmonary vascular resistance, right ventricular strain as evident by NT-proBNP, Borg dyspnea score, time to clinical worsening, and functional class. And we appreciated that there was a significant improvement across all endpoints with a very robust p-value in comparison to placebo. So this allowed for approval by the FDA for the use of this medication in functional class 2 and class 3 pulmonary arterial hypertension. Its sister study looked at the role of this medication in patients with chronic thromboembolic pulmonary hypertension. These were patients who had a clot that was unresectable because of whatever reason, or they were resected and they still had residual chronic clot in their pulmonary vascular bed. And the data was convincing here. Again, significant improvement across all treatment parameters except for time to clinical worsening. And it afforded us approval of this medication for the use in patients with unrelenting clot or residual clot after pulmonary endarterectomy. So let's take us to our second case study. This was a 28-year-old female who had a history of asthma. She had palpitations and dizziness and was referred to a local cardiologist. He said, wow, this isn't normal for such a young lady. Let's do a full workup. The workup suggested pulmonary arterial hypertension. He took her to the cath lab. She did indeed have pulmonary arterial hypertension, and he did what any red-blooded American would do. He started her on sildenafil, right? So this is what he found at physical exam. He found that she had a resting tachycardia. She had murmurs of right heart failure and a heave. The echocardiogram supported that with an estimated right ventricular systolic pressure of almost 80 millimeters of mercury. Her 6-minute walk distance, 420 meters, seems pretty reasonable, but we'd like our patients to get above 440 or better. Below 440, it suggests the patients aren't optimized. Below 330, increased risk for mortality. The right heart cath supported the echo findings. Her mean pulmonary arterial pressure was greater than 25 at 44. Her wedge pressure was less than 15 at 9. Her pulmonary vascular resistance was greater than 3 at 9.5 Wood units. And on sildenafil, when I saw her 2 months later, she had an improvement in her 6-minute walk distance by 20 meters. Her exam and echo were unchanged. And she was still having problems. She was still complaining of symptomatology, and she felt short of breath, even on the medication. And the question arises, what are the treatment options for this fairly typical patient with pulmonary arterial hypertension? So this takes us to what we used to do and what we should be doing. What we used to do was we would start the patient on sildenafil or bosentan or ambrisentan, and then we evaluate them and watch them. And then when they came back not walking as well and complaining of a little bit more symptoms, we'd up-titrate the dose or we'd add another medication. And what that shows us is that, unfortunately, we're potentially missing opportunities where we can help to remodel the pulmonary vascular bed and the right ventricle by addressing their disease process early and aggressively. So the shift in the paradigm is, instead of doing sequential management, we do aggressive upfront management with combination or maybe even triple therapy in these patients to try to impact outcomes. And today, in 2016, monotherapy for the management of pulmonary arterial hypertension is passé. It's a thing of the past. So we risk stratify these patients, and Dr. Polk sort of lended to this. The REVEAL data gives us an ability to generate a risk score by looking at certain parameters that we measure on a routine basis in these patients to try to determine whether these patients are at high risk for mortality within 1 year, greater than 10%. And we use different domains to identify our risk: the patient's symptoms, their 6-minute walk distance, and what the right ventricle and pulmonary vascular bed is doing at echo and at right heart catheterization. And our goals for treatment is to improve survival. And this is reflected by decrease in clinical worsening, an improvement in quality of life, trying to get these patients down to functional class 1 and improving their right ventricle. So this takes us to the Seraphin study, looking at the newest endothelin receptor antagonist, macitentan. The treatment group were treatment-naive patients and patients who had background therapy with either a PDE5 inhibitor or an inhaled or oral prostanoid. These patients were considered stable, functional class 1 and class 2 disease, and they were considered sufficiently treating according to historic guidelines that we use. The primary endpoint was morbidity as well as mortality, including atrial septostomy, which is us poking a hole in the atrium to unload the right ventricle and then the right atrium, lung transplant, the initiation of IV or sub-Q prostanoid therapy, or hospitalization. And this is what they found. In red is the folks on drug, on macitentan. In blue are the folks who are placebo. And they showed over a 36-month treatment period that there's a 45% risk reduction in the primary endpoints, death or morbidity with patients on macitentan, 10 milligrams a day. And when we looked at the patients who were pretreated, who came in the door already on drug, taking a PDE5 inhibitor and or an inhaled or IV prostanoid, there was a 38% risk reduction in the primary endpoints. And this is predominantly hospitalizations and time to clinical worsening. So it reflects that macitentan is an excellent medication to initiate on patients, but also it's an excellent medication in combination with other conventional medications available for the management of this disease. And it speaks to a number of other studies that have been done historically where there's been add-on therapy, where the patients were already on drug and we added a second or maybe even a third drug to their regimen and showed improvement in quality of life, improvement in outcomes, and improvement in time to clinical worsening. Takes us to our next case study. This is a 45-year-old female with a 5-year history of scleroderma who was newly diagnosed with pulmonary hypertension. Her PCP had been doing serial echocardiograms on this woman because they knew that we need to screen for pulmonary hypertension in this woman, and the echoes were normal. And we'll speak to that when we have the Q&A. Her exercise tolerance, however, was declining. Because of her high risk for pulmonary arterial hypertension with the scleroderma and her exercise intolerance, she was taken to the cath lab and was found to have pulmonary arterial hypertension, as evident by these values. Her mean PA pressure was over 25 at 29 millimeters of mercury. Her wedge pressure was less than 15 at 5 millimeters of mercury, and her pulmonary vascular resistance was greater than 3 Wood units at 4.9 Wood units. So what do we do with this patient? So the rationale for using combination therapy is multiple. As we discussed already, there's 3 pathways of management for pulmonary arterial hypertension. So if we put this patient on sildenafil, we're only treating the endothelial receptor pathway. There's 2 other pathways that are going unchecked. And hence, we're missing an opportunity to try to optimize treatment by covering all of our bases. We think that by using combination medications, they act synergistically to reduce disease. Knowing the severity of this disease, we recognize that these patients, even on treatment, their mean mortality rate is 8 years. So we need to take advantage of opportunities at the onset of treatment to try to optimize their therapy so that we can extend their lifespan. And we're already seeing models of how to use combination therapy in other disease processes with success. We all manage our advanced COPD patients with a LAMA and a LABA and an ICS. We manage our pneumonia patients with a beta-lactam and a macrolide. We manage our CHF patients with beta blockers and afterload reducers and diuretics. So we're used to using combination therapy, and there's no reason to think that combination therapy won't work in this population. So we're going to look at the current data looking at combination therapy with an endothelin receptor antagonist and a PDE5 inhibitor. And this was a pivotal and breakthrough study that was published as a lead article in the New England Journal of Medicine just last year. It was the Ambition study that looked at the initial use of Ambrisentan plus Tadalafil in patients with pulmonary arterial hypertension. This is upfront therapy. Day 1, you make the diagnosis. Day 2, you start them on combination therapy. So this is the algorithm of treatment. They had 605 patients, both functional class 2 and class 3 disease. There was a 2-to-1 randomization. So for every 2 patients that receiving combination therapy, 1 patient would receive Tadalafil, another patient would receive Ambrisentan or Letairis. The study was concluded at 105 primary endpoint events. A primary endpoint event was the time to clinical failure. Clinical failure was death, hospitalizations because of worsening pulmonary arterial hypertension, short-term clinical worsening, meaning that their 6-minute walk test had dropped by 15% over 2 consecutive visits, or inadequate long-term treatment. They weren't improving their functional class over 6 months. And this clinical endpoint was driven by hospitalizations because of their pulmonary arterial hypertension. So the graphs are pretty evident. Black is the combination therapy, blue is Letairis, black is combination, red is Tadalafil. And in the combo group with Letairis, there was a 49% risk reduction in disease progression in comparison to the monotherapy with Letairis. And in the Tadalafil monotherapy group, there was a 45% reduction in risk of disease progression compared to monotherapy with Tadalafil. So this speaks to the fact that combination therapy improves outcome relative to monotherapy. And this is the first time that we had an upfront study that used this strategy and that showed improvement in outcomes regarding clinical failure. It also reduced the risk for disease progression, it reduced hospitalizations, it improved exercise tolerance, it improved right ventricular strain by reducing NT-proBNP, patients had a higher satisfactory rate, and their 6-minute walk distance improved. And this has a Class 1 Level B recommendation by the American College of Chest Physicians and the European Respiratory Society. So let's talk about the non-prostanoid IP receptor agonist. This is the newest baby on the market. This is Selexipag. This is an orally active IP agonist. It has a specific affinity for the IP receptor. It has been shown to reduce pulmonary vascular resistance. And the adverse effects improve over time with this agent. The predominant adverse effect is diarrhea, but it gets better even as we advance the medication. So Griffin's study was a multi-center, double-blinded, placebo-controlled parallel group study that assessed the long-term safety and efficacy of Selexipag in patients with pulmonary arterial hypertension. The patients were in functional class 2 and class 3 disease. There was a robust clinical endpoint, the time to first morbidity and mortality event to the end of the double-blinded treatment phase. At baseline, 20% of the patients were on monotherapy, 80% of the patients were on either single or dual therapy, of which 33% of these patients were on combination background therapy. So 33% had 2 drugs on board already. Selexipag was gradually up-titrated to the maximum dose or to the dose of tolerance over the study period. And this is the Kaplan-Meier curve that looked at Selexipag versus placebo. The study group was over 1,000 patients, and they looked at primary endpoint, which was death or disease progression related to pulmonary arterial hypertension that resulted in hospitalization, the institution of IV prostanoid therapy, the institution of long-term oxygen therapy, or the need to poke a hole in the atrium to unload the right atrium and right ventricle. And what they found was pretty amazing that there's a significant reduction in morbidity and mortality of 40%. And again, this was driven by a reduction in the need for hospitalization related to pulmonary arterial hypertension and the reduction in disease progression with excellent hazard ratio and p-values. So this is the last study we're going to touch on, and this is a very small study by Sitbom and his colleagues in 2014 where he took 19 patients with advanced pulmonary arterial hypertension, functional class 3 and class 4 disease. They were all very young, and he put them up front on 3 drug therapy, IV Epoprostenol plus an ERA plus a PD-5 inhibitor. And at 4 months, their 6-minute walk test had increased significantly. Their mean pulmonary pressures had dropped by 20 millimeters of mercury on average. All of them went from functional class 3 and 4 down to functional class 1 and 2. One patient did need an emergent lung transplant. At 3 years out, all patients were still at functional class 1 and 2, and their survival as far out as 5 years was 100%. So that's very telling. As we look through the management of these patients, we need to make a collaborative agreement with a local center of excellence that manages pulmonary arterial hypertension, or find an expert in our community who has a significant interest and passion for this disease process, because as Dr. Polk alluded to, and as this slide reflects, there's a lot of areas where pitfalls can be made, and a lot of hurdles to have to jump over, and it's a lot of burden for folks who don't have a passion for this disease to try to have to understand, manage, and follow. And we need to take advantage of the specialty pharmacy, specialty nurse, big pharma support groups, Pulmonary Hypertension Association, and Caring Voices, and other support groups that are available for our patients and ourselves. So the future direction for the management of this disease, we think that triple therapy is going to be the mainstay of therapy. We just need larger studies to confirm what these smaller and combination studies reflect. 3D computer modeling of the pulmonary vasculature in the right ventricle is going to have a place, hopefully within the next decade. There are some novel approaches to delivery of medication. This is one, the Inopulse delivery system for inhaled nitric oxide for potential home use. Targeting inflammation. We know that when we target HIV patients with antiretroviral agents or target our scleroderma patients with immunosuppressives, their PA pressures improve. So there's some consideration for targeting inflammation in other patients with PAH. We have to treat this disease as a cancer and look at apoptosis and epigenetics. Stem cell research. Thankfully, Obama was in office and allowed us to do more stem cell research. And we think that with that, cardiac regeneration and angiogenesis may play a role in the management of this disease. So in summary, treatment for patients with pulmonary arterial hypertension is based on our initial evaluation and risk assessment. Treatment should be delivered by clinicians who have a passion for this disease, and these patients should be referred to pulmonary hypertension centers. And ongoing monitoring for the response to therapy and reassessment is critical in these patients. And we're seeing that there's an increased armamentarium of agents and modalities and approaches to managing this disease, in particular upfront combination or even triple therapy, as evident by the data we're seeing by REVEAL, as well as some of the more recent pivotal studies. And we need to consider this particularly in patients who are declining with conventional therapy. And I thank you. Oh yeah, post-test. Post-test. All right, which of the following medications? Oh, one caveat, that last question, we'll have to throw that out because it was wrong, and we'll talk about that. Which of the following medications are FDA approved, used in the management of WHO Group 1 pulmonary hypertension? Diltiazem, Ambrisentan, Digoxin, or Epoprostenol? Answers: 1 is A and C, 2 B and D, 3 A, B, and C, 4 all the above, 5 none of the above. Answer now. Okay, slamming. You guys got it. There you go. All right. So we touched on this. Cardiac calcium channel blockers is non-FDA approved. Only a select number of patients are going to fall. About 7% of patients with idiopathic pulmonary arterial hypertension are going to meet criteria for the use of calcium channel blockers. Digoxin is a supportive therapy. The effect on the right ventricle is variable. We use it, but it's not an FDA-approved medication. So there you go. Next question. If a 35-year-old female patient with SLE presents to you complaining of shortness of breath with walking, and her RV is overwhelmed with an elevated pressure of 62 millimeters of mercury plus the CVP, and with a normal LV ejection fraction as estimated by the 2D echocardiogram, is it reasonable, acceptable practice to then start her on low-dose sildenafil? True or false? Go. You are absolutely, you nailed it. Do not start a patient on PAH medications by an echo interpretation. You are mismanaging your patient. You're practicing malpractice. These patients have to be sent to the cath lab, and a right heart catheterization needs to be done to confirm the diagnosis of pulmonary arterial hypertension. When we look at data from the folks at Temple University about 5 years ago, they looked at patients who had advanced lung disease who were listed for lung transplant. And they took them all to echocardiogram, and then they took them all to right heart catheterization. And they found that the echo was right only 50% of the time. So the echo is a subjective study. It relies on the echocardiographer to put the probe in the right position, and then it relies on the cardiologist to have a passion for what? For the right ventricle. And sorry to say, most cardiologists don't. And they underinterpret or overinterpret. And it takes me back to that slide where the doctor was doing the echoes all the time and they're always normal. If I have a patient who is high risk for pulmonary arterial hypertension, if I have a high index of suspicion for this disease, I'm taking those patients and asking them to do an echo under stress. Because the echo may look fine sitting here writing and scribbling and talking, but when you try to walk 20 feet, the echo may flounder and fail, and that may be the culprit for why they're getting short of breath. So if the echo is always normal in a scleroderma patient, I'm having a low threshold for a cath, But before that, I'm sending them to the echo lab and asking them to exercise that patient to see what that right ventricle does with exercise. All right, next question. Okay, same patient. She went to the cath lab, and her pressures were on the echo were confirmed at right heart cath with an elevated mean PA pressure of 45 millimeters of mercury and a normal wedge pressure, and her pulmonary vascular resistance was elevated. Is it acceptable to practice? Is it a reasonable and acceptable practice to then do the following? Immediately start her on low-dose sildenafil, send her to the pulmonary hypertension center, start her on diltiazem, start her on digoxin and warfarin. It's a trick question. Good. So I don't think anyone would frown upon you starting this patient on sildenafil with the understanding that you're going to get her to the doctor that has expertise in this arena. So I think for those of you who answered 1, that's okay, thumbs up, with the understanding that you're going to also answer 2. Those who answered 2, thumbs up as well. As far as 4 is concerned, there is data showing that warfarin does improve survival in the patients with pulmonary arterial hypertension, idiopathic. So I wouldn't have any problems with you starting her on warfarin with the understanding that you're sending them to a specialist. Digoxin, I don't think there's a role there. And obviously, everyone nailed it. There's no role for calcium channel blockers. And the last question, the answer here, we all know it now. We've gone through this, is anti-CMP pathway. The question was worded wrong. It should have been all except 3. 3 is not a pathway. And I thank you very much.